Good evening, Sameer sir. Good evening, Dr. Rohit. Good evening, Dr. Tanvi. Sameer sir, can we start with the session or we are waiting for Ashish sir to join?
Ashish will join soon. Anyways, he has
Yes, sir.
second session, so we can start without any further delay.
So on the behalf of NOEL, we welcome our esteemed guest faculty members. So we have with us today Dr. Tanvi, who is a fellow in Neo Clinic Children Hospital. And with moderating this session will be Dr. Rohit and Dr. Jaikishan Mittal, sir. So this month, it will be the West Zone Noel session. And as discussed, we thought to keep it as a air leak to be the theme of this month.
Okay.
For the air leak being the modality high frequency ventilation, so we thought why not to start with a high frequency ventilation as a part of a seminar. So I request Dr. Tanvi and Dr. Rohit to take over the session. The first part will be the basic and the pathophysiology. And the second part, which is the application of the high frequency ventilation, this part will be taken up by Dr. Ashish Mehta, sir. So yes, over to you, Dr. Rohit. You can start the session.
Okay. So, good evening, everyone. So, the screen shall be switched off. My screen shall be by name of Dr. Tanvi, and Dr. Tanvi's screen shall be by my name. So, just last moment, some tech issues. So, right at the outset, I'll like to thank the NOEL committee for giving us the opportunity to speak on this important emerging topic, high frequency ventilation. I think the main idea after this, or a main message, would be that we should be able to judge when to use HFO, how to use HFO, and learn regarding the basics of the same. So, without wasting much time, I'd like to request Dr. Tanvi to start with a presentation. I think, Dr. Gunjana, the Q&A answer session will be taking at the end, right?
Yes, yes.
Okay.
So, Dr. Ashish also prepared a couple of Q&A. Am I the only one, or maybe Rohit sir, your voice is coming pretty low.
Okay, sir.
So maybe I should not happen the same thing with Dr. Tanvi. So just Dr. Tanvi, a little request to speak a little louder.
Sure, sir. Am I audible, sir?
Yeah. That's why the voice is coming a little kind of, a little lower. So kind of one needs to put your ear on the screen to listen to what you are saying. Something like that.
Okay.
Can you speak a little louder, or can you attach a microphone or maybe your simple headphone with if you're doing it through laptop or maybe through in a mobile also? Or try.
Tanvi, just try to speak a couple of lines.
Good evening, sir. Am I audible?
Yes, I think audible clearly.
Is it okay, sir? Sameer, sir, car video is paused.
I think it's fine.
Tanvi, you can just keep your voice a little louder. Otherwise, you are clear. Maybe you can come near to your laptop and then speak up so that the things will be a little more clearer.
Sure, ma'am. I'll try my level best to be as loud as possible.
Yeah, still your voice is little low. I think you have to be a little loud.
Okay, ma'am.
You can start.
Should I start?
Yes.
Yes, please, Dr. Tanvi.
Okay. Good evening, everybody. Today, I'll be talking briefly about high frequency ventilation, which is like an emerging modality for us. The moderator would be Rohit sir. So in 1915, Dr. Henderson observed a panting dog and thought to himself that if a dog can maintain the breathing ventilation with rapid shallow breathing, then maybe some similar mechanism should work for us humans also. High frequency ventilation is a form of mechanical ventilation that uses small tidal volumes, often less than the anatomical dead space, and extremely rapid ventilatory rates. The tidal volume which we use for a high frequency ventilation is that low, which is lower than the normal tidal volume, which is 1 to 3 ml per kg. Normally, when we use conventional ventilation, we use a tidal volume of more than 4 ml per kg, 4 to 8 ml per kg. In high frequency ventilation, it's a generic term that encompasses any mode of assisted ventilation that operates at a frequency 4 times the natural breath. The potential advantage of such ventilation are prevention and treatment of lung injury, the ability to ventilate patients that are impossible to ventilate in any other way, and the ability to separately control oxygenation and ventilation. So basically, when we're using conventional mode of ventilation, there are certain injuries that happen to the lung, which are ventilator-associated lung injury, namely volutrauma, barotrauma, biotrauma, atelectrotrauma. So in high-frequency ventilation, what we're trying to do is provide small tidal volume with rapid rate to prevent all of these. The types of high-frequency ventilation. There's high frequency flow interruption, which is basically modified conventional ventilation operating at a very high rapid rate. Then there is high frequency jet ventilation, which is produced by ventilators that deliver a high velocity of gas by flow interrupter. And then there is high frequency oscillatory ventilation, in which there is moving air which is produced back and forth at the airway opening while generating minimal bulk gas flow. It is defined by any device that uses reciprocating pumps by a piston, a diaphragm, or generates sinusoidal waveforms and vibrates air in and out of the lungs at a frequency of 180 to 3000 breaths per minute. These are the basic differences in all three types of high frequency ventilations. In high frequency flow interrupter, flow is generated by sinusoidal solenoid valve. In high frequency jet ventilation, there's a pinch valve or injector cannula which produces the jet. And in high frequency oscillatory ventilator, there is electromagnetic piston or a diaphragm which oscillates at a rapid rate to produce that ventilation, to provide that airflow. The main difference in all of these three is that in high frequency oscillatory ventilator, even the expiration is an active process. Usually in the ventilation, inspiration is active and expiration is passive. Whereas in HFOV, even the expiration is controlled actively. All of these three work at a different frequency. The most wide range of frequency is from HFOV, which we'll be studying today. There is an added feature in all of this, which is psi superimpose. In certain HFO, high frequency oscillatory ventilators, we have a CMV setting in which we can give super added breaths, voluntary breaths, to provide adequate tidal volume in between, which is more than the ventilatory rate of the HFO. Now we'll be talking about why HFO. Why is HFO better than the conventional ventilation? Or why we are using HFO? HFO provides a higher MAP, improved alveolar recruitment, which leads to an improved alveolar recruitment, leading to better oxygenation. By smaller tidal volumes, it prevents alveolar overdistension and volutrauma. Low peak pressures reduces the barotrauma, and a smaller gradient between the inspiratory and expiratory pressure prevents the cyclic distension and collapse of alveoli, hence decreasing the atelectrotrauma. When HFO? What are the indications in which we use HFO? Some studies have mentioned that HFO can be used as a primary modality also in treating extreme preterm babies with RDS. But there is still insufficient evidence for using HFO as a primary mode. Mostly we're using HFO as a rescue mode, which is more commonly used when there is failure of conventional ventilation or uncomfortably high pressures are required. In cases of moderate to severe lung diseases such as RDS, pulmonary hyperplasia, MAS, congenital lobar emphysema, BPD, pneumonia, and atelectasis. We can also use HFO with PPHN. mainly for pulmonary air leak syndrome such as in pneumothorax, emphysema, PIE, bronchopulmonary fistula, HFO can help. In cases where there is severe chest wall movement restriction due to high pressure over the diaphragm, HFO can be helpful, such as in NEC and CDH. If we talk about the index, oxygenation index of more than 15 is an indicator that where we can use HFO and can be found helpful. When is it that we need to use HFO with a lot of caution? One, when we're dealing with pathophysiologies where there is air trapping happening, gas trapping is there. HFO at a rapid rate might accentuate the problem also. So we need to be careful. It's indicated in air leak syndromes also, and it may cause problem in that also. So whatever we do, we have to do with caution. Also in case of shock, because when the baby is on HFO, there is a higher MAP, which is mean airway pressure. It reduces the venous return. It may also amplify the hypertension. So this now is the basic pathophysiology of how an HFO works. There are 5 mechanisms that happen simultaneously to maintain ventilation through an HFO. I have divided these 5 mechanisms into 3 categories in which it is basically describing where the mechanism is acting. So in the proximal airway, the one thing that is happening is bulk. In the mid airway, I will be discussing all of them separately also. In the mid airway, there is pendulum effect, there is Taylor dispersion, and then there is asymmetric velocity profiles. And in distal airway, there is cardiogenic mixing and collateral ventilation. So in bulk convention, see what we do in conventional ventilation is we are giving a adequate tidal volume with the jet of inspiratory air, which is reaching to the terminal alveoli for gas exchange to happen. That mechanism is not helping us maintain the ventilation in HFO. But because we are giving some amount of tidal volume, which is lower than the anatomical dead space, it is going to go somewhere in the lung. So that direct ventilation will at least ventilate the proximal part of the airway. Like we can see in this image, the gray part, which means the inspiratory jet is not enough. The tidal volume is not enough to reach the mid and the distal airway, but it will ventilate up to some level the proximal alveoli, the proximal airway, through the bulk convention method, which is the basic inspiratory gas is going in and ventilating the proximal airway. The second is the pendulum effect. At higher frequency, gas distribution is strongly influenced by time constant inequalities. And there is redistribution from full fast filling units to slower filling units, augmenting gas exchange. So what this means is all the alveoli in the lung, every alveoli is different from the other, and all alveoli have different time constants and different compliance. So the alveoli with good compliance take more time to fill, and alveoli with poor compliance fill faster. So their filling and emptying happen at a different rate. So alveoli that fill faster, empty faster also, and the slow filling alveoli are still empty after filling. So once the fast filling alveoli is emptying, some amount of air is instead of going into the expiration also goes into the alveoli, which is still in the filling phase, the slower filling units. That is how through pendulum effect, gas not only just goes through in during inspiration, it also ventilates the alveoli near it from alveoli to alveoli also before the previous next inspiration can come in. Then the third mechanism and the fourth mechanism are Taylor dispersion and asymmetric velocity profiles. So inspiratory and expiratory both are active processes, both are happening simultaneously. Both inspiration and expiration happen at a different velocity. These asymmetric different velocities happening together create a sort of turbulence in the airway, which leads to more dispersion of the gases. Taylor dispersion basically means when there is an inspiratory jet, like we can see in this image, the blue gas is the inspiratory jet. So when the inspiratory jet is going through the airway, it disperses the expiratory air to the periphery, increasing the surface area and increasing the mixing of the gases. So the oxygen dense gas in the inspiratory air and the oxygen poor source of gas in the expiratory air also go undergo mixing. It increases the surface area and further increasing the dispersion of gases, the diffusion of gases. So basically in Taylor dispersion, there are three things in relationship are helping the gas exchange. One is the axial velocity profile, different velocities of the inspiration and expiration causing a turbulence, which is further increasing the dispersion process, the diffusion process. Then there is diffusion of gases in motion and the branching network of the lungs. Then in the distal airway, there is cardiogenic mixing. What cardiogenic mixing means, because in HFO, we are constantly keeping the alveoli distended, the beating action of the heart is leading to some sort of diffusion in the pericardiac region also. Directly, because of the pressure changes, the beating action is also causing some sort of diffusion from alveoli to alveoli in the distal airway. The last one being collateral ventilation or molecular diffusion. When the alveoli is completely constantly distended, the adjacent alveoli come in more close contact to each other, and through pores of cone, there is certain fusion from alveoli to alveoli also, furthermore increasing the gaseous exchange and the diffusion. So there is this image to conclude all the mechanisms together. So instead of just giving one tidal volume, one pressure with one pressure giving inspiration, we are doing many small things at the level at different levels to maintain the oxygenation and ventilation through HFO. In this, we can see that basically two things are happening: diffusion by convection and diffusion. In the proximal and mid airway, there is one is direct ventilation in the closed alveoli. Then there is turbulence due to the asymmetric inspiratory and expiratory velocity profile, pendulum effect, which is filling of one alveoli from the other alveoli because of different time constants and compliance. And then by diffusion in the distal airway, one is diffusion from alveoli to alveoli, collateral ventilation through the pores of cone, and cardiogenic mixing. Now, in brief, I'll be talking about the variables in HFO. This is our HFO here, SLE 5000, in which we use. And the parameters we can see on the screen are IE ratio, the HFO rate, the mean, which is the mean airway pressure. Then there's delta P, which is the amplitude, and FiO. The benefit of HFO, like we said before, is that we can control oxygenation and ventilation separately, independent of each other. The oxygenation is controlled by MAP, which is the mean airway pressure, and the FiO2. And the ventilation can be controlled by delta P, which is the amplitude, and the frequency, which is the rate. Mean airway pressure. MAP provides a constant distending pressure, which is equivalent to that of CPAP. This inflates the lung to a constant and optimal lung volume, maximizing the area of gas exchange and preventing alveolar collapse in the expiratory phase. Increase in MAP increases the oxygenation. The optimal lung inflation is 8 to 9 intercostal rib spaces on chest X-ray. The amplitude, delta P or power, is the variation around the map. Amplitude controls the force with which the piston moves in and is measured in terms of pressure, which is centimeter of water. The movement results in a gas volume displacement and a visual chest wiggle. The primary control to enhance CO2 removal is amplitude. Increase in amplitude washes out CO2. In high frequency oscillatory ventilation, the amplitude is dependent on the movement of the piston in the ventilator. Like we studied before, the HFOV works on the principle of a piston or a diaphragm. The movement of a piston or the diaphragm, the vibration causes the inspiration and expiration. The forward movement causes inspiration and the reverse causes expiration, making the expiration also an active process. The adequacy of amplitude is indicated by visualizing a chest wiggle, which ideally should be noticed up till the umbilicus. In adults, the same happens up till the mid-thigh. Poor noticeable amplitude may be due to a poor noticeable amplitude or a wiggle may be due to small ET tube size, tube blockage, chest wall rigidity, use of conventional style circuits which are compressible. An increase in wiggle at the same amplitude suggests improvement in the compliance of the lung. The presence of asymmetrical wiggle, as when compared with both sides of the chest, may indicate an pneumothorax or a tube block. Frequency. Frequency controls the time allowed for the piston to move. The optimal frequency produces the best ventilation with the lowest delta P and tidal volume and no gas trapping. Smaller the patient, higher the optimal frequency. Patients with short time constants can be ventilated at high frequency and vice versa. As compliance improves, frequency should be reduced. And as resistance improves, which means if the resistance decrease, frequency should be increased. This is a volume time graph in HFO. This is showing on the x-axis is the baseline, which is showing the frequency. On the y-axis is the amplitude, the mean airway pressure, and the area under the curve represents the stroke volume. By this image, we can understand that why is it so that when in the conventional ventilation, when there is CO2 retention, what we do is we increase the rate so that there is more washout. Whereas in HFO, it happens the opposite way. In HFO, decreasing the frequency will lead more CO2 washout. And why is it so? Because when we decrease the frequency, there is greater volume displacement leading to greater stroke volume, hence leading to greater CO2 removal. FiO2, increase in FiO2 directly increases the oxygenation. The initial FiO2 is kept same as we use in the conventional ventilation. A higher FiO2 with a reduced MAP is attempted in case of air leak syndrome. IE ratio, unlike the conventional ventilation, no TI or TE is set. IE ratio is preferably kept to be 1:2. A 1:1 ratio can increase oxygenation but may also lead to air trapping and CO2 retention and impedance of the venous return. If oxygenation is satisfactory and CO2 clearance is poor, a ratio of 1:3 may be tried. However, the same is usually successfully achieved with a lower frequency range. Diffusion coefficient of CO2. Like SpO2 on the monitor gives us a real-time idea of what PO2 will be. This is the benefit of HFO, that diffusion coefficient of CO2 on the HFO monitor or the screen of the HFO gives us a real-time idea of the PCO2 level in the body. Like I would like to come back to the slide where there is an HFO. In HFO, the parameters here that we can see, breath per minute, tidal volume, here there is this coefficient which is diffusion coefficient of CO2. If we calculate, I would come back to this again. So, diffusion coefficient of CO2. It is the measure of alveolar ventilation in a high frequency oscillatory ventilator. It is calculated by frequency into the square of tidal volume and is expressed at ml square per second. So, by all the parameters that are given on the HFO screen, we can calculate the DCO2. So what we need to do is initially, when we put a baby on HFOV, we take a blood gas and we calculate the DCO2 with the set parameters, that what the tidal volume is produced by the settings and at what frequency that is so. And we can calculate and compare the PCO2 with the DCO2 on the screen. Later on, by tracing the trend of the DCO2, we can actually compare what the PCO2 would be like. For example, by the formula, we calculate an actual DCO2, which should be in the ideal case. If there is more DCO2, which means there is more alveoli CO2, which means there will be more washout in the capillary. Like there is one capillary and there is alveoli. This is telling us alveolar ventilation. So this is telling us how much CO2 is there in the alveoli. If it is more than the expected, then there is less CO2 in the capillary blood, which means there is more CO2 washout. If it is so that it is less than the expected in the alveolar ventilation, that means there might be a CO2 retention. So this gives us a real-time idea of what the PCO2 status would be in the baby. By tracing the trend of which we can monitor more frequently and reduce the blood gas monitoring. These are my references. Thank you.
Great, Dr. Tanvi.
Yes, sir.
It was nice, illustrious presentation. I hope you have prepared a couple of Q&A to be taught at the end of the session. And I think Dr. Ashish Mehta sir is also on, was already logged in. So I would request Ashish Mehta sir to kindly take over the next session. And if time permits, we'll take a Q&A right now, or maybe we can do it later on also. So Ashish sir already started. Yes. So
Yeah.
thank you, Dr. Tanvi. Thank you so much. Welcome, Ashish sir.
Thank you, sir.
Yeah. Is it visible to everyone?
Yes, sir, it's visible.
Okay, great. Thanks, Dr. Tanvi. You have decreased my burden a lot. And it is going to be a good repetition of the things that has already been said. But then I'll have my own way to discuss that, isn't it? So let's talk about HFE. In fact, I thank Samir too for this topic because this is very close to my heart. And this is one of the ventilation, one of the technique where, yes, when a consultant or clinician is perspiring and seeing that baby is getting respiratory hypoxic failure and you got nothing in your hand, at times, not every time, at times this is the one which can save someone's life, and that's why I love it. But having said that, there are a few things which we must learn, and my presentation will be based on that. So we have been doing mechanical ventilation for ages now. Everyone would be doing all our unit must be experiencing 2 decades of ventilating babies. And in current era, most of the ventilation is non-invasive. We understand that. But then there is a group where they need invasive ventilation. And most of us are okay with basic mechanical ventilation. We end up with lung injury, that also we know. And lung injury is because of 2 reasons. One is ventilation induced lung injury, and one is ventilation associated lung injury. So let's talk about those pictures that we see at times in our unit. Pneumothorax, one lung is totally collapsed. You try to open it up, the ribs are also collapsed, ends up with very bad pneumothorax. We drain it, but still difficult to recruit this collapsed lung. And when you can look at histopathology, you can see there is enough of the damage to the lung in form of barotrauma, volume trauma, fibrosis, thickened septas, absent hyaline membranes. So many things goes on. When you look at the etiology of this thing, basically with mechanical ventilation, of course, this is before volume guarantee era, where we do not have any control on the peak pressures. Neither you have any control on volume, on the volume that you deliver. Within 2 to 3 days of, I will show the one slide next after some time, where within 2 to 3 days after mechanical ventilation, the basic lung, base of the lung starts collapsing. At the same time, part of the lung is open, part of the lung is collapsed, and that causes atelectasis. You try to open it up and close it, and that causes volume trauma, barotrauma, atelectasis. Increases infection or any manipulation in the respiratory tract causes inflammation, causes biotrauma, and we know about surfactant trauma and uncontrolled flow which goes into baby's lung. All these traumas are related to ventilation. Not necessarily it is only mechanical ventilation. Even high frequency also can cause all this. So the problem is that all this ultimately, as I told you earlier, that you can see this slide. This is at start. You can see well expanded lung. After 20 hours, 24 hours, you can see the collapse is at the base of the lung. And within 2 days, you can see the collapse that has happened at the base of the lung. And this is nothing to do with ventilation. This is simply that baby or a human being is not breathing on his own. He's been tubed, and the change of the flow, or the I'll say the gas exchange, all this will lead to this kind of problem. We try to open this lung, and all this opening efforts to open this lung can cause enough of the damage. As I told you, this damage causes disruption of the alveolar and bronchial epithelium. It causes formation of hyaline membrane. There is a leak in the protein, in the leak of the protein air spaces. There is oxygen toxicity. All this will lead to the dreaded outcome or dreaded morbidity of newborn lung in form of BPD. So the logical thinking would be that if I want to avoid volume trauma, if you want to avoid barotrauma, or if I want to avoid lateral trauma, I would like to minimize the pressure. I will like to minimize the volume. But when I try to do this, obviously, we all know that alveolar ventilation is equal to tidal volume into frequency. So when you try to decrease the tidal volume or minimize the tidal volume, you need to increase the frequency. So you need to find out a ventilator which can help, which can ventilate a baby with minimal posterior pressures, which can deliver minimal tidal volume, which can deliver high frequency to maintain alveolar ventilation, and that is where the concept of high frequency ventilation. In first decade of this century, the concept of open lung strategy came up in the picture, came up in the light. Right from the delivery room, scientists realized that don't allow the lung to collapse. And that is how people started talking about CPAP, 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 sustained inflation. This is a different word used. Ultimately, the strategy was to keep lung open by minimal pressures or by delivering surfactant in the delivery room. How can I do that? There are two strategies. Number one, keep a maximum respiratory units open. So recruit the lung. When it is collapsed, try to give the pressure to recruit the lung. And once it is opened up, during inhalation and exhalation, make sure it stays open. And that is open lung approach. So when you talk about HFE, this is the ventilation or this is strategy which can meet with the logic that we used in last two slides. This is a ventilation which uses supraphysiological breaths. We know that normal rate is 60 per minute. And when you talk about supraphysiological, you are talking about rate of at least more than 300 per minutes. And when you are breathing high rate, you are delivering a tidal volume which is lesser than the dead space or equal to dead space. So the thinking, so the concept is whether that small tidal volume will able to ventilate a sick lung or a sick baby. So in all, as earlier been said, that hallmark of HFE is to use small tidal volumes. Sorry. Hallmark of the HFE is to use small tidal volume. Conventional ventilation, we use tidal volume of 5 ml per kg. At times we go to 7 ml per kg. But in high frequency, you are using 2 ml per kg. And as I said, that we are using frequency which is supraphysiological rate. Alveolar ventilation, as we know, is frequency multiplied by tidal volume minus dead space volume. So now imagine that if both are equal or tidal volume is just about dead space volume, how the alveolar ventilation is happening. In the previous presentation, Dr. Sheetal nicely explained different theories behind how high frequency volume causes gas exchange, and even with the small tidal volume, the ventilation is happening. So let's talk about different HF ventilator. For conventional ventilation, as we know, the flow is going from the one side, patient is getting ventilated, and there is exhalation valve through which the exhalation flow comes out. So you can talk about high frequency positive pressure ventilation where your item is small and you are talking about the rate of 120 to 150 per minute. Normally, with conventional ventilation, we ventilate at 60, at the most 70, very rarely, but 40 to 60 will be physiological rate, and that is with which that's the number with which most of the babies will be ventilated. Same ventilator can go as a high frequency positive pressure ventilation, where conventional ventilation uses supraphysiological breath with minimum I-time and try to do the exchange. When you talk about HFOV, high frequency oscillated ventilator, you can see here that flow is going from one side, patient is being ventilated here, and exhalation valve is there. And along at this valve, you can see there is a piston sitting here. And this is a piston which will move and keep on pushing air in and out. So that means that there is active inspiration and active exhalation. The exhalation valve which is sitting here, which may or may not, depending on the ventilator that you are using, which may or may not push some jet air over here to keep maintain pressure in this area. So typical high frequency oscillation where you have got a piston moving here, it will something like, sorry, it will be something like, it will be something like this picture, and the standard product, standard HFOV ventilation, which is stand-alone unit, is sensormatic, which is very strong, very sturdy. It is based on this particular principle that oscillation causes active exhalation and active inhalation. Then you talk about high frequency flow interrupter or high frequency jet ventilation. Flow interrupter are the one which interrupts this flow, which is bias flow. When you talk about jet ventilation, HFJV, there are two ventilators sitting here. One is the control one is your jet ventilator, conventional ventilation, and other is your jet ventilation. And the jet ventilation will keep on pushing flow of jet intermittently into this area, which goes to the patient. And there are some ventilator where you have got exhalation valve sitting here, and flow interrupters are working at this stage, intermittently cutting this flow, and because of that, the flow is going in and coming out. And that is how this will happen. Different kind of ventilators are available in the market. I'm not here to market any of this ventilator, but if you understand the basics of HF ventilation, you can ventilate any of this. As I told you, the standard is Sensormatics. Problem is it is standalone and the cost is also a problem. So what is happening with high frequency oscillation? You can see the valve oscillated. It gives amplitude. We'll discuss about the amplitude little later, but this is typical of your oscillation, where you can see that, sorry, this flow interrupter, where it keep on oscillated at this level. And because it interrupts the flow at this level, it keep on pushing the gas in the expiratory limb so that intermittently the flow is coming out. These are different ones. SLE, he has got two. Sorry, yeah. There is an exhalation valve. An exhalation valve has got two opening here, and you can see here that because of this two opening, there is a intermittent venturi effect into the exhalation limb. Because of this, the active exhalation and the passive inspiration and passive exhalation is happening. We'll not bore you with all this thing, but these are the different ways by which one can see. What is effect of some of my videos are not working today? I'm sorry for that. These are all the videos which I wanted to show you. Anyway, let's go. So, which are the different parameters that you are going to adjust while ventilating baby on high frequency? In conventional ventilation, you got PIP, you got PEEP, you got flow, you got FiO2, you got rate, and there is I time. So there are 6 parameters typically in conventional ventilation. What happens in high frequency? There are mainly 3 parameters which are MAP, mean air pressure, there is a frequency, and there is amplitude. Rest all are important, but not that important as far as ventilation or adjusting the parameter of ventilator is concerned. So which are those? How do you manage those things? Only 3 parameters. With MAP, like a CPAP, you inflate baby's lung, and then let it wobble with the power and with the rate. So the power with which it is working is amplitude, and the rate at which it is working is frequency. So in short, you open up the lung with some power, you oscillate it or vibrate it or wiggle it, and with rate, there is per minute, you try to remove the CO2. So basically, as far as oxygenation is concerned, in high frequency, oxygenation is managed with mean air pressure, with FiO2 and I time. CO2 elimination happens with amplitude and frequency. So this is one of those things where, remember, in conventional ventilation, oxygenation and CO2 elimination are overlapping. MAP can control both oxygen and CO2 elimination. FiO2 can control only oxygen. Rate can again control both, because rate, PIP, PEEP are determinant of MAP, and MAP is the one which helps in oxygenation and CO2 elimination. With high frequency, it is decoupled. Oxygenation means MAP, FiO2 and I time. CO2 elimination means amplitude and frequency. Here you can see that this is mean air pressure. That's the pressure at which the lung is opened up. And then there is a piston or expiratory flow in form of venturi effect or interrupter, whatever you say, with which the flow is getting in and out, in and out. So the power with which it is happening is your delta P. If you remember, delta P in conventional ventilation is equal to PIP minus PEEP, difference in the peak and the low pressure. Same thing here, the peak is here, the low is here, the difference is delta P. And then the rate at which this is happening over a period of time is the frequency. So these are three important determinants of gas section in high frequency ventilation. So how do you apply it clinically? As I told you, amplitude is the piston with which the power is given to that flow. It affects PCO2. MAP, it is the pressure around which ventilator oscillates, that is oxygenation. And frequency is the rate, again it is determinant of, it helps in CO2 removal. 1 hertz is equal to 60 breaths. Imagine you are oscillating a baby. If at 10 hertz, you are talking about 60 attempts of putting gas in and bringing that gas out per minute, which must be, we wonder how much cardio volume will it be exchanging. But mind well, it is very strong. In a derecruited lung, it works like wonder. Now, with conventional ventilation, we know that water MAP or water pressure or water PIP that you achieved at the proximal airway, same PIP will reach to the distal airways. We know that. And that is known as a time constant. The time required to equilibrate proximal and distal pressure is your time constant, one time constant. And we all know that three time constants required to achieve proper equilibrium of almost 95 to 96% between proximal airway and distal airway. That means whatever pressure that you achieve at the proximal airway will reach to the distal airway within the I time that you have set on the ventilator. In high frequency, that is not the case. You can see the pressure transmission at the proximal airway is maximum. But as it passes through the alveoli, you can see it dampens right to almost less than half than what you applied at the proximal airway. Betterly graphic you can see here that HFO is conventional. In conventional, the pressure transmission is equal right from the top to the alveoli. In high frequency, you can see here it dampens down. By the time it reaches alveoli, very small fraction of the gas is reaching there. And that's a concept we do not want to over expand. We do not want to keep it collapse. We just want gas exchange till the pathology is resolved. So oxygenation, friends, it is MAP and FiO2, nothing great about it. I already discussed that it opens up the lung and it can be adjusted directly in high frequency ventilation. We know that in conventional ventilation, there is no knob for MAP. MAP is to be adjusted directly. MAP is calculated thing. You can't adjust MAP on the conventional ventilation. On high frequency ventilation, you get separate knob with which you adjust the MAP. So to optimize, idea is to optimize the lung volume, to optimize the alveolar surfaces, to recruit the lung, to improve the area of gas exchange. So most important part of MAP or of high frequency is recruit the collapsed lung and keep it recruited, prevent further collapses. So one thing is that, but extreme part of that is that if you are overzealous in recruiting lung, it can also cause over distension and also can cause air leak, which is one of the complications of high frequency ventilation. So both extremes are there. We want to open up the lung. If you do overzealous this, it causes over distension. And we all know that when the lungs are over-distended, pulmonary pressure increases and it causes other problem that will be discussed later. Again, the same repeating, this is a compliant lung, this is non-compliant lung. In non-compliant lung, you can see here that even though non-compliant, you can the gas flow keeps on decreasing, the pressure also keeps on decreasing from airway opening to the alveoli. While in the conventional ventilation, which is given the darker line, it remains the same. Now coming to ventilation. Ventilation is alveolar ventilation. Alveolar ventilation is CO2 removal. And CO2 removal is amplitude and frequency. These are two parameters with which the CO2 removal can happen. So what will happen? Tidal volume is equal to delta V, we know what is amplitude, which is controlled by the forces with which the oscillating piston moves, distance traversed by the piston. The longer the distance, more with the power, shorter the distance, less with the power. And frequency already there, rate with which this has been done is the frequency. The degree of difference between vital volume, nothing great. The deflection, the power that you offer will be reflected clinically in form of wiggle. We see people, those who are already ventilating with high frequency ventilation, they know that vibration or wiggle is the clinical demonstrator of amplitude that you offered. You can see here the same principle. The pressure that is being applied as it goes, this is again about the frequency. This is 6 Hertz, this is 12 Hertz. At lower frequency, there's a better area for the better time for the gas section in comparison to the higher frequency. And how does this happen? We'll take in the next slide. So lower the frequency, you can see the frequency is less, more area or more time, I'll say not more area, more time for the gas exchange. Now, I already told you that conventional ventilation, alveolar ventilation is equal to rate into tidal volume. While for high frequency ventilation, CO2 removal is rate into tidal volume square. So small changes in the tidal volume can bring big change in the CO2 removal. And this is been termed as dCO2, which is dissociation coefficient for CO2. D is dissociation coefficient for the CO2. And the formula for the dCO2, as I already mentioned, is tidal volume square into frequency. So small change in tidal volume, simple small secretions in the ET where the tidal volume is not been delivered, that small change causes sudden increase or decrease in the CO2, and that is to be kept on the mind. You can see the different diseases here, and frequency will vary upon the size of the baby and the kind of disease that you are going to manage. You can have frequency of 5, as at 5 Hertz, 1 Hertz is 60. So you're talking about 300 frequency, and range is 300 to 900. So from 300 breaths per minute, that is 5 Hertz, one can level it right up to 15. Again, I am telling you that depends on the size of the baby. We'll discuss a little later, and depend on the kind of disease that you have. Now, what happens with I time? There is no separate knob for the I time on the ventilator. It says I ratio. And I ratio normally we try to keep it 1:2. And that means in a given case, whatever will be the total cycle, 33% will I time and 66% will be E time. And that gives a ratio of 1:2. If you talk about 10 Hertz, that means and 33% inspirated time or 1:2 I time, it gives I time of 0.03 seconds. Minuscule. You talk about 0.35 second in conventional, in high frequency, you talk about I time of 0.03 second. So there is hardly any time for the gas to reach there, and that also in small amount and comes back. And that takes care of that very delicate lung of the baby. If there are situations where inspiration CO2, where the oxygenation is problem, yes, you can change that I time. You can increase I time but not as if in number. You can change the ratio from 1:2, you can do 1:1. And when it is 1:1, 0.5 is I time and 0.5 is E time. When you decrease I time from the 1:2 to 1:1, we need to understand it is happening at the compromise of the E time. So when you change to 1:1, your expiry time is decreasing. In that case, probably air trapping will happen, gas elimination will be less than the higher times. So the question is that we know now that oxidation parameters are MAP and FiO2 and I time. CO2 removals are the frequency and amplitude. Which are the strategies? How are you going to ventilate in which babies are going to use this? Different causes, different indications are there, we all know. Homogeneous lung, heterogeneous lung, air leaks, atelectasis, PPHN. For any lung pathology, one can use high frequency. And then you got, should I use as a rescue or should I use a prophylactic? We'll discuss it little later. How will you start? Mean air pressure, if you are starting as a rescue mode, you can start from 1 to 2 centimeter of water higher than where you were on conventional ventilation. So when you are on conventional ventilation, if your MAP is 12, you can go to 14 on high frequency ventilation. But again, this depends on the kind of disease that you are facing. In an oxygenation problem or in a non-recruited collapsed lung, hypoplastic lung, non-homogeneous diseases, you are talking about going up on the MAP. While air leaks or other issues, you try to go same or little lower on the convention on the number that you are with which you are ventilating conventional ventilation. For example, on conventional ventilation, baby has got pneumothorax at 12 of MAP. With high frequency ventilation, you cut it down to 10 or 11. But again, all this based on the clinical condition, how the baby is behaving by decreasing MAP. At what frequency will you start? I already explained you earlier with the slide that bigger the baby, smaller will be the frequency. So in our typical meconium 3 kg babies, your frequency will be 8, 9 or 10. But in a very bad HMD or very bad pneumonia, small babies like our 1.2, 1.5 kg babies, maybe you are talking about 12, 14 or 15 of hertz. And we know that higher the hertz, lesser will be the time for the gas exchange. Lesser will be the CO2 removal chances. Lesser will be hypocarbia and other issues. Amplitude should be sufficient to keep that wiggle moving or to look at the chest motion. So normally we say that it should be double of MAP to start with. So if your MAP is 12, you can start with 24 of amplitude and then look at the wiggle. We need to see that baby's chest up to groin should be wiggling and not more than that. If the thighs are wiggling, that means your amplitude is too much, which is not good for the baby. You may need to come down on that. We'll discuss it again little later. Your target would be keep the pH in the normal range, PCO2 30 to 40, PO2 80 to 100, no one goes to 100 these days, 62 I will say, and bicarb of about 20 to 24. We know this part, amplitude how to select, as I told you, double and look at the wiggle. So if you are doing rescue strategy, so already you are failed on conventional ventilation, your FI2 will be same as what was already there on conventional ventilation. Your mean air pressure will be little higher than conventional ventilation. For meconium aspiration, you may got little higher because you know the lungs are very stiff. Big babies require more MAP or stronger MAP to keep the lung open. In RDS, respiratory distress syndrome, you are just going little above because these are delicate lungs. And air leak, as I told you, you are going below what you can see, what you are done with CMV. Amplitude, twice the MAP as adjust, and bigger the baby, smaller will be the number for the frequency. Smaller the baby, bigger will be the number for the frequency. If this has been studied as elective, because you like the hyperventilation, you find that these lungs are very bad right from beginning, say antenatally diagnosed pulmonary hypoplasias. There is no way out to open up this lung. You tried with conventional ventilation, you end up with more barotrauma and volume trauma. So these are hypoplastic lung. You do not want to damage those already compromised lung. In that case, high frequency is the one which is whatever recruitment it can happen with high frequency, with minimal barotrauma or no barotrauma or volume trauma. And that's why there are cases where you electively go for a high frequency ventilation. Again, it is unit policy. There are few units in the world, smaller babies, right from word go. I'm talking about 600, 700 grammars. Right from the word go, they are using on HFJV, particularly Japan units, and few units like IO and Sweden, they are all right with the with the low volume, high frequency ventilations. Anyway, for elective strategies, you start with FIO2. MAP is not take the number. You look at the chest X-ray and decide what your MAP you adjust is right or not. You want to open up the lung, you are looking at least 8 to 9 posterior ribs on the chest X-ray. There is adequate expansion. Amplitude based on the vehicle right up to the groin of umbilicus, and frequency, as I told you, bigger the baby, smaller is the number. You put this baby on ventilation, but you are struggling with oxygenation. Still, the hypoxic respiratory failure is not allowing to get away from the baby or to have a good sleep. Saturation is still hovering around 80-85%, let's say. Effort is 100%. And this borderline hypoxic baby would deteriorate or decompose at any time. So our aim would be to improve oxygenation. And there are two strategies with which oxygen can be improved. One, look at the chest X-ray and keep on increasing MAP. For example, I started with MAP of 16, and with that my chest X-ray showing 6 to 7 rib. I know that there's space for me to improve the MAP. So from 16 I go 18, 18 to 20, but keep on doing lung ultrasound or keep on doing chest X-ray to confirm the lung expansion. But there is another way by which you can do that. That you just with the first strategy that I discussed, up to what level I will increase? That is always a dilemma. How many chest X-ray will I keep on taking to confirm that lung has opened up? That is always a dilemma. So then you are looking at the sustained inflation or the alveolar recruitment strategies. What is that? For this strategy, you should not be peepophobic, you should be peepophilic. You should not be worrying about the PEEP or MAP that you need to increase that you need to improve that you need to improve the lung volume. Typically, this is a time, this is airway on the y-axis. You keep on increasing airway pressure till you reach optimal inflation. How would you know that optimal inflation? At point B, you will start realizing that because lung has opened up, now FR2 has started coming down. Your SPO2 is getting better. And that is your optimal lung inflation. Open lung strategy. Once you reach there, you want to see that is this optimum or is over optimum or over extension. So try to come down by 1 or 2 MAP from point B to point C. The moment you come here, the lung is deflated a little bit. And because of the deflation, again your SPO2 will drop, effort will increase. That means you again need to recruit to the previous level. From C, you go to the D point, which was just equivalent to B or just below B. And that is your optimal inflation. This chart is from Goldsmith. You can see here that your SPO2 86 to 94%. FI2, you have set the FI2 to maintain this. Your initially pressure is X. You keep on increasing FP pressure 1 to 10 centimeter every 2 to 3 minutes. That means you are standing in front of the baby and you dialing up your minimum pressure till your SPO2 improves. You can see here. And that is your opening pressure. Once you are reached, again you increase the 1 to 2 centimeter every until the SPO2 falls, FI2 below SPO2 falls or FI2 goes below 30%, 25%. So by increasing your MAP, you find out that now things are getting better. SPO2 is getting better. But up to what level you want to increase? You want to increase to a level where your SPO2 is so good that you started coming down on FiO2, which is something like 25 to 30%. That means lungs have opened up now. But you do not want over distension. You do not want air leaks. So try to come down. Sorry. you try to come down on pressure a little bit. Again till your SpO2 starts falling. Mind well, we are not doing gases. We are standing in front of the baby here. You are doing this in per every minute, 2 to 3 minutes you can mention here. And once you find that by decreasing your pressure from the previous number, your SpO2 has started falling down, that means your closing pressure. You need to go up again to make sure that your pressure your FI2 stays below 30%. So your opening pressure is lesser than the airway pressure is lesser than the maximum pressure. This is the principle. That is your optimal pressure. And that is typically recruitment strategy. Believe me, the cases where you find that things are going beyond the control, stay there. Don't worry about the number on the map. At times you end up going 22 to 23. Now, beauty is that once lung has opened up, a baby is on high frequency, you come down on map, still lung stays open. So de-recruit a little bit, but still because the previous it was recruited, lung will never deflate that quickly. It stays open and helps in the better gas exchange. So that was about how to deal with oxygenation. Let's talk about what happens by changing amplitude on the blood gases or overall overventilation. This is a scenario where we are ventilating a baby at frequency of 15 and I ratio of 1.2. I put this baby on amplitude of 15. This is the membrane through which the gas is moving. This is endotracheal tube and here is baby's lung. So this is amplitude. You have started delivering the gas. You can see because of the endotracheal tube, there is a dampening here. So when you're talking about 15 hertz with the use of 3 endotracheal tube size 3, 10% of the pressure amplitude of 15 is being conveyed beyond the ET tube to the length. Only 10% of amplitude of 15 is being conveyed. That's fact. And as I told you, what is tidal volume? The difference between high and the low pressure, that is a delta P. This much term is delivered when you are ventilating baby with size 3 tube. If I decrease your amplitude from or increase amplitude from 15 to 13 without changing the frequency, what is happening? You can see here. Dampening is already happened, but you can see here. You can see here that your tidal volume has increased. Here there is no change in your frequency, but because of increase in the amplitude, tidal volume has increased. That is what we will believe. So as I told you, that CO and better tidal volume, better CO2 removal. So ventilation, alveolar ventilation, amplitude, increase amplitude, more CO2 clearance, decrease amplitude, less clearance. What happens with the frequency? You can see here that this is a scenario where amplitude is 30, I ratio is 1.2, frequency is 15 hertz. And with this, you can see here, that by decreasing the frequency, this is decreased frequency, this color. With decreasing frequency, there is more area for the gas exchange. Why so? Because I time has increased from what it was with the higher frequency. With 50 frequency, I time was this, where by decreasing frequency, I time has increased. So absolutely opposite to the conventional ventilation. With conventional ventilation, we know that by decreasing rate, you are decreasing tidal volume, and by decreasing tidal volume, there is less CO2 exchange. Here in high frequency, by decreasing rate, there is more I time, more time for the volume to get in touch with the lung, so more gas exchange. So by decreasing rate or frequency, there is more clearance of the CO2. That is typical of high frequency. Now what happens that you are changing frequency and amplitude both? How does it help? So in this scenario, you can see here that amplitude is 30 and 15 is hertz. And with that, this is tidal volume. Now from 15, I'm decreasing to 8 hertz and also decreasing amplitude. With that, even though I decrease the frequency, normally we learn earlier in the earlier slide, by decreasing frequency, you are going to get more gear exchange. But if you decrease the frequency and simultaneously decrease the amplitude, there is not much change in the gas exchange because IE ratio remains the same, or I time remains almost the same. So therefore, when decrease frequency, one must also decrease amplitude to maintain PCO2 in the same range. In short, again, MAP, FiO2 and I time is oxygenation, frequency and frequency and amplitude is CO2 removal. Higher the amplitude, more CO2 washout. Lower the frequency, more CO2 washout. This is clear. Higher the MAP, better oxygenation. Now different variables. If baby's oxygen is inadequate, atelectasis, poor lung inflation on X-ray, that means lung has not opened up. Your lung is collapsed, X-ray is not good, and because of that, oxygen is not getting better. Only one thing is going to do, you improve the MAP and consider sustained inflation for 10 to 15 seconds. On X-ray, lung is overexpanded with or without hypercarbia. As I told you that overzealous increased MAP also can cause the problem. You look, the moment you find the X-ray beyond 9 posterior rib, irrespective of what the baby is, try to cut down on the MAP. That's only one thing that you can offer, otherwise we will end up with the leak or the pneumothorax. So the moment is overexpansion of the chest X-ray beyond 9 posterior rib, cut down on the MAP. Hypercarbia with normal lung volumes, what to do? Increase amplitude or decrease the frequency? Hypocarbia, decrease amplitude, CO2 washout. CO2 retain the CO2, decrease amplitude, increase frequency. Hyperoxia, first reduce FiO2, then MAP. And loss of wiggling means your tract is, there is a problem with your endotracheal tube, or there is too much of the rigidity in chest wall, there's a mucus plug, you need to rectify those things. This is what in day to day, in day out, this is what you're going to face, and according to, you need to rectify this issue. So we have put a baby on ventilator. We know how, at what number you are going to start, and we know how to change the settings based on the concept that we have discussed. Amplitude when to change, how will you affect the oxygenation, how will you affect CO2, frequency when to change, how it will affect the CO2 and oxygenation or MAP. Which are the indication? Basically, we know how to do this now. But where are you going to do this? Which are the cases? Are you going to do in all the cases? Typical will be homogeneous lung diseases. Best result will be homogeneous lung diseases. And typical will be very bad pneumonias, very bad RDS, meconiums, it open up the meconium plugs and all that, failure of constitution and PPHN. As of now, well accepted mode of ventilation for airlick syndromes. Preferable to conventional ventilation for patients with severe uniform non-RDS like diseases like PPH and pneumonitis, pulmonary hypoplasias, and cases like your congenital hernias, or you can first try it before say that nothing is going to help my baby's lung, it is all out, better go for ECMO. One can try off for high frequency and wait for that. Two strategies, rescue and prophylactic. Prophylactic word generates lot of curiosity, that can you use this as a prophylactic high frequency? We know prophylactic surfactant, we know prophylactic antibiotic, and nothing is good for the baby. Is the prophylactic high frequency is good for the baby, and for what you are going to do that? There is no indication for prophylactic. It is unit's preference that the unit is well versed with the high frequency prophylaxis, particularly in small babies like 600 or 700 grams, where even little bit of ventilation or conventional ventilation can cause trauma. And recent evidence nowadays is coming up that prophylactic high frequency in that particular group is working good for the babies. At times it is doing good for certain combinations like PPHN requiring INO. That's the one where high frequency INO is better than the conventional and INO. There are disease surgical conditions like gastrochiasis, omphalocele, NEC where lung is distended and do not allow where the abdomen is distended and do not allow the lung to open up. And severe oligoadrenal sequences where intrauterine problems have caused hypoplasia. These are the cases where it is being useful. Now, in current era, how will you equate high frequency or how will you rate high frequency in your for your day-to-day usage? All research that we have seen is almost at the time of surfactant or the anti-steroid era, first decade of this century. In second decade, 2011 maybe onwards, you got good ventilators, and most of the babies stay on conventional ventilation or stay on non-invasive ventilations. There is a concept of permissive hypercapnia. You do not want to treat all CO2 as 35 to 45. If pH is fine, you are all right keeping the CO2 at 50, 55 1 without any problem with the long-term neurological outcome. So why do you want to unnecessarily overstress the lung? Why do you want to unnecessarily change the machine to keep baby high frequency or change the circuit to use high frequency and label that CO2 is normal, and that's why the long term is going to be good. We are in different era where permissive hypercapnia is all right. Our knowledge of keeping SpO2 in the lower or oxygen target has improved. In a sick baby, at times you need to weigh the situation whether I want to traumatize the lung or I'm okay with a borderline SpO2 with equally good long-term outcomes. So 85 to 88% for time being, till the baby comes out, that the patho is resolved, you are all right keeping SpO2 around 85. Not for all the babies, not for all the days. In a given case where the baby is falling sick, for example, body bed pneumonias, aspirations, milk aspiration, which is going to improve in next 3 to 4 days by antibiotics, by proper lung strategies, nutrition, all those things. So why unnecessary to keep this with the anti-inflammation? And in a current era where now got good volume ventilation happening in a smallest baby, we have got good ventilators which can manage with the smallest tidal volume. So in this context, how much of help high frequency ventilation is going to be, that is questionable. Anyway, since for this topic, yes, there are cases where it is works like a magic, but not all. Once baby is on high frequency ventilation, there are so many other issues. Which are those? Most important point, as I told you, that from the proximal to the distal airway, the air pressure flow dampens. And that's why, and if the endotracheal tube is not proper size, there's too much of the leak, there is a hardly any flow will go to the baby's lung because of the leak itself. In that case, one need to make sure that appropriate size endotracheal tube is being used. Checks the X-rays, some say once a day, some say twice a day. I will say whenever required, not as a routine. One need to train your nurses to keep an eye on the wobbling, because every now and then you are not going to ask for the blood gases. Every now and then you are not going to suction the baby. Every now and then you are not going to look at the chest X-rays. Wobble too much, that means lung is recruited well, come down the amplitude. Too less wobbling, check the airway. If baby is sick, increase. If baby is not sick, is more of an airway problem. Suctioning is not regularly asked, particularly disconnecting a baby, that too again, disconnecting baby for suctioning is no good for the ventilation. It will de-recruit the lung. The efforts that you put in to open up the lung is all gone, is zero. So that's why if at all you put a baby on high frequency one, try to see that you get inline suctioning, so de-recruitment should be a problem. And hemodynamic monitoring is must. As I told you, the lung and the heart goes hand in hand. Too much of the overexpansion, PVR increases, more shunting, more vacuum mismatch, and the problem. So these are the cases where you may talk about something extra volume in this. We're not talking about 20-30 ml per kg. To begin with, you may offer 5 to 10 ml per kg of volume extra to make sure there is MAP or the mean air pressure is not causing any problem with the venous return. Vagal factor we already discussed. Which are adverse effect? We know that when there is a problem, we use high frequency, but high frequency also is not without any complications. We discussed that hyperinflation is not good. Not only it causes air leak, it causes decreased cardiac output, peripheral shutdown, decreased blood pressure, desaturation, all these problems. Pneumothorax we discussed. Too much of the pressure can also cause IVH, and also it can cause trauma or I'll say airway trauma because of too much of shear pressure offering to the baby. Once on high frequency, how will you win? First is FI2 we know, and second is amplitude. But there is no first and second. If vigor is too much, come down amplitude. If speed is suddenly improve, come down to FI2. But your attempt will be to cut down on the FI2, reach to 30%. Now, should I change the I ratio? No need to do that. Should I change the bias flow? There is no question of changing bias flow. All machine will take their flow, will decide how much flow is required to adjust those amplitude and to adjust those frequencies or map. So we do not have any control on bias flow on high frequency ventilations. And in fact, in current era, most of ventilator they are pressure control or volume control ventilation, where the flow is decided itself by the ventilator. In all, you are winning on the FI2, you are winning on the map, you are winning on the amplitude. We are not winning on the frequency unless there is sudden change in the CO2 high or low. Some of it all depends on your confidence, whether you want to change from high frequency to conventional or you want to extubate from high frequency. It is your own unit expertise or a confidence in particular strategy. We try to extubate state of high frequency to non-invasive ventilation. It is not must to change from high frequency to conventional and then conventional non-invasive, CPAP or HFNC, whatever you want to. So it's all your strategy, but the fact remains the same, that bring down the minimal setting and then extubate. If you want to go to conventional, go to map of less than 12, 15, 12, 13, FI2 of 30-40%. And with that, if you got good chest section, good gas volume, good gas, you can go to conventional. When to stop? Is it effective or not effective? All babies on high frequency will not improve. There are few who will not like high frequency at all. So once you are conventional and as a rescue strategy you use high frequency, you do not give up right from, let's say, within 10 to 15 minutes. Give some time for the baby, for the lung to recruit, number one. Use different strategies, sustain inflation, lung recruitment strategies. Do not worry about the map. Keep on going on a map and see what happens. And with all these maneuvers, if oxygenation is the primary purpose of using HFE as a rescue is not served, in that case, you can give up on a frequency and go back to conventional ventilation. Certain FAQs which I would like to answer. Can I do suctioning with HFO? Yes, you can do, but try to use inline suctioning. High frequent ABG is done. It is as good as your conventional ventilation, but at least before putting on high frequency, and maybe after half an hour or 1 hour of after starting HFE, you can at least one gas is required. Frequency of the gases will be more frequent than conventional or non-invasive ventilation. Why so? Because this is very strong ventilator strategies. As I told you, dCO2 is equal to tidal volume square into frequency. Simple change in the tidal volume will bring huge change in CO2 clearance or CO2 removal. And lung pathology is dynamic. Right now looking good, but over a period of time, suddenly right now looking bad, but with your antibiotic or proper positioning, automatically the pathology improves. And once the lung pathology improves, the tidal volume delivered will be very high. It will bring down the CO2 like anything. So maybe with high frequency, you need more frequent gases, but how many frequently? Not necessarily 6 early, not necessarily 12 early. I'll go by the baby's clinical condition. If effort is coming down, vigor is good, you can go by the ventilator screen also, because ventilator screen also is going to deliver tidal volume HFE and dCO2. Based on that, you can decide whether you want to get gas or not. Would escalation have? May or may not be. You are looking at the wiggle at the typical high frequency sound you can auscultate, but all the time it is so noisy that difficult to make any decision in a small baby, small chest based on the auscultation. Yes, people like to put sigh breath in between, so IMV per high frequency, but maybe this is like once upon a time kind of strategy. We do sigh breaths in high frequency when required, very occasionally, not as a routine. Chest movement alone will not help, but it does help a lot. And yes, HFVG, again I'm talking about a small group of the babies, 6 and 8 grammars, where lungs are really very, very tiny, and small change in the numbers that on the ventilator will bring big change in the gas exchange. We all believe that volume trauma is worst of all trauma. So we want to catch the volume. And like conventional ventilation, HFE also has got volume guarantee. Not all ventilators, but there are most ventilators which has got volume control over HFE volume. And it is always good to have both in your hand, map in form, pressure in form of map, and the volume guarantee, a volume in form of volume guarantee. What Cochrane says, it decreases CLD in a small reduction, but it is not consistent. Mindwell, recent trial, anterior steroids were given, surfactant given timely, basic delivery room management is given, nutrition been cared of. Those trials, they started showing good outcome of small babies with high frequency, and that's why there are few units they right from birth go they use high frequency jet ventilation. This is only restricted for the unit they are already mastered conventional ventilation strategies. If with those strategies still the BPD rate in the unit is very high, in that case, you can use high frequency as a rescue strategy or as a prophylactic strategies. Yes, there's increased rate of air leak that everyone knows, and there are no big changes in the neurological outcome, no long-term or short-term neurological outcome between two ventilation strategies, conventional versus high frequency. In all, it is exciting and relatively new form of mechanical ventilation for us, particularly with volume guarantee and high frequency. It is linked with CPAP, which wobbles, CPAP oxygenates and wobbles ventilates. Baby with diffuse lung produce best result on HFJV. In neonate, RDS along with surfactants plays a role in better long-term outcome CD. Superior to CMV in airlicks and as a rescue in thumb babies, but it is not panacea for all problems related to ventilation. It is not must to have it. Why? Remember, newborn is a demanding individual. Whichever method of ventilation is used, clinical observations, bedside vigilance, timely action, human touch, tender care cannot be replaced by any technology. Thank you very much.
Thank you so much, sir. It's always a pleasure to listen to you. And we have some couple of questions, sir, in the chat box. Maybe you can take up that. So the very first question that we have, sir, is at what map on high frequency ventilation we should decide that the baby requires surfactant?
That means I understand that already baby was given surface. I mean, I don't have the number to tell the truth. It is again the clinical situation because this is a baby. I look at the X-ray. X-ray is very bad. Homogeneous lung disease, whiteout lung. I'm talking on high FiO2s. I'm sitting on high MAP. Better to give surfactant. Surfactant is not a panacea for all the problems that you are going to face. It is going to transiently improve oxygenation. It is going to buy time. Now, if this is a full-term baby, think twice before using surfactant. In a preterm baby, earlier the better, that we all know. But having said that, if you are facing a situation where hypoxic respiratory failure is causing problem, and because of that you need to keep on increasing mean air pressure to control that kind of situation, better give surfactant. But mind well, in this baby, opening up the airway to deliver surfactant itself can also cause the problem. These are very sick tiny babies, need to be very careful about even giving surfactant or disconnecting airway to give the drug.
Another question that we have, sir, if you may please explain the delta P concept in HFO again.
Delta P?
Delta P concept.
Delta P is basically delta P in conventional. We already know the difference between the PIP and PEEP. Same is here. For example, you have got 12 of MAP and I have got 24 of delta P. As I told you, we started double. So from 12 of MAP, the piston will be moving 12 up and 12 down. That is your 24 of delta P. So your piston is moving from, that means 12 up will be 24 and 12 down will be 0 on the pressure graph. So the piston is moving or the volume is moving between 0 and 24, and that is your 24 delta P. I hope it is clear.
Another one that we have, sir, is in changing the frequency slide, if frequency is reduced, will amplitude increase?
Yeah, that's what I'm saying, that when you are decreasing the frequency, what will happen? Your gas section will improve. Your CO2 will come down. So given a situation where gas is showing that it will come down on the frequency, and in that case, the CO2 will be washed out. If I want to balance that, what I'll do? I'll decrease the amplitude also. So that both will move in the same direction. That is possible. Just want to show highlight that. Don't allow frequency to go down to a level where CO2 is washed out, and then you want to compensate by so decrease the amplitude at that time, provided baby allows to you to do that. Your wiggling has to be perfect.
Is it recommended to paralyze for HFOV?
I don't remember when I last paralyzed any baby in current era. Only 1 or 2 baby, maybe in last 5 years we have paralyzed, but those are very sick babies. There is no way out. Baby was struggling a lot, mainly because of the inadequate, efficient ventilation they were struggling. And we want to take full control of the situation, particularly very bad very bad diaphragms with hypoplastic lung. These were the cases where you want to take full control of ventilation. In that case, you are using paralyzing. Otherwise, as a routine, no paralyzing agents. Because already KG Anand that pain trial already shown that paralyzing is not good for the long-term outcomes. And paralysis itself has its own side effects. So that's why to keep away in paralyzing them.
What is the maximum frequency we can go in relation with MAP, twice or thrice or even more?
Smaller the baby, go to 15, 16, something like that, never beyond that. At least I have not used that. I don't know maximum number, but 15, 16 will be reasonable frequency in a small babies. At the most, I have heard the stalwarts using 18 frequency. But personally, we have good 15, 16, a very small baby, 600, 700 grammar, and that too for small time. Otherwise, you're all right less than 15.
What is the maximum MAP that we can go up to open up the lung?
22, 26, 28. Don't be pupophobic. Be pupophilic. Once you want to open up the lung, roll up your sleeves, get your pneumothorax ready. But these are once in a while situations, not as a routine. Like a baby has come from periphery, very badly septic, lung is fully like very stiff lungs, and you see white out. Everything has been tried, nothing is working for our baby. What else you can do? ECMO is not there in my place. Ideally, I would put this before ECMO. It is not there. What shall I do? Dial up the map. And it has worked in few babies, I must say that. It works. There are places where they just dial up map right from beginning. Open up the lung, stay there, and let lung improve. So I don't have the number, but personally gone to 24, 26, 28, but once upon a time sort of situation, not as a routine.
Weaning strategy from HFO.
Yeah, once start coming down to the FR2, that is one. Once you reach to 60% less, you can talk about decreasing the map. And then maybe again it is a clinical situation. If your still effort is getting better, SPO is getting better and better, keep on decreasing map along with that. The priority is from whatever number you are, try to bring down effort to below 60. Once you reach there, cut down on the map. Then you cut down again on the FI2 to 40, cut down on the map. And once you reach to minimum map and minimum FI2, either conventional ventilation or depending on expertise or your faith in HFE, you can extubate straight from HFE to non-invasive ventilation or HFE to conventional.
How much delta P should be increased for high PCO2?
Only delta P is not good. Again, there is no relation. You know that that we had by increasing 10 of MAP, you decrease the CO2 by this. This is what we learned in the blood gases. We do not have the number and we don't have the exact, but you increase the MAP ultimately. If you are increasing MAP, but looking at the wiggle, it is not that simply you are increasing the MAP. If the wiggle is too much, there is no point increasing the delta P. You need to cut down on the frequency because you want to get rid of that CO2. By decreasing frequency, there is better CO2 exchange or CO2 removal. So don't look at the delta P all the time only. If your delta P, your vigor is too good, baby's vigor is too good, and CO2 is still high, after ruling out other common causes, blocked tube, inappropriate size of endotracheal tube, so many things are there. After ruling out those things, you can cut down on a frequency.
What is the maximum delta P in relation to the map, twice or thrice?
Twice. But again, I mean, these are subjective things, you know. This is, I don't have the number. I'll be with the baby. If vigor is good, there is ideal delta P. I can't make it thrice because someone told me. We start with twice of delta P from map, and based on the clinical scenario, wiggle and the gases and DCO2, you decide whether this is adequate or not.
So these are the questions that we had, sir. Thank you so much, sir. Over to you, Sameer, sir.
Thank you so much. It's always such a pleasure to listen to sir, and always, you know, at this hour of the day also, sir is so impeccably dressed. So that's the something which I love about Ashish sir. Thank you so much, sir. Thank you so much for taking out time, Dr. Tanvi.
I'm
You
sorry,
are
I want to show
excellent.
you some good videos. Somehow it is not happening today. There's really good videos I had, but somehow could not show that because that lung
So
inflation, the animal model,
you
I
can
want
play
to.
in video individually just by logging off from the presentation. You must have saved those somewhere.
Yes. Let me try. Somehow for Zoom it is not happening. I can see in my laptop, but for Zoom it is not happening. Because I took permission of Mangala to show this for this presentation. I can do that. Look at this. Yeah, it is happening. Just a minute.
A unique valveless system to deliver extra power and more safety for your patients. A typical neonatal patient serves a unique valveless system to deliver extra power and more safety for your patients. A typical neonatal patient circuit consists of an inspiratory limb and an expiratory limb. A patient Y allows the circuit to be connected to the patient's ET tube, and a constant 8 liters of heated and humidified blended gas is fed through the circuit. This is known as the fresh gas or bias flow, and usually exits the rear of the ventilator without having any effect on the patient. The SLE 6000's valveless system is contained within an exhalation block that connects to the expiratory limb, ready to control the flow. Inside this block are 2 turrets that feature 3 directional jets. When you want the patient to receive a breath, a forward-facing jet gives a controlled pulse of air. This acts as a pneumatic piston, adding to the bias flow and diverting gas into the patient's lungs via the Y connector. This pulse enables the delivery of breaths for each patient to be dynamically controlled. Increasing the rate will increase the number of breaths. Increasing the inspiratory time of each pulse will result in longer breaths. There is also the option to shape and control each breath by adjusting the rise time, as well as modifying the pressure of each pulse that is delivered to the patient. A consistent feature of any mode is a second, forward-facing jet, delivering optional CPAP or PEEP. Unlike a mechanical valve, air has no significant inertia or delay. Therefore, using the same jet, The rate can be increased easily up to 20 Hz or 1,200 breaths per minute, whilst managing the flow and pressure with immense precision. This
Now we are connecting with the high frequency, and you can see that map has gone to 15, 16. The lung is recruited. Even the bases are opened up. Basal part, you will turn on the other side. This is one of the ventilation workshop. Now we have started decreasing capacity, the lung stays open. But once recruited, the lung never deflates, it stays open. From 26, it has gone down to 19, but still the lung is open. That's the beauty of this particular slide. And then
sliding. These are quick. Yeah, quick.
for suctioning, this is what happens. When you open the baby for the suctioning, this is what happens. And this is when the PEEP is 0, you can see all the alveolus closing. There is no PEEP. And when PEEP is 5, you see few recruitments there. Now you can see it is not closing. I will again show the 0 PEEP. Look at that. Everything is collapsing. Now with 5, it opens up. Not working fully. Make it 10, 15. Look at that now. Can you imagine? No one would use PEEP of 15. None of us. But if you want to open up the lung, you may go beyond what the normal conventional number will allow you to do that. And then this is what high frequency will do. You'll open all of them and just keep on doing gas exchanges. Yeah.
Great. Thank you. Thank you so much, sir. Thank you so much to all the participants who have stayed so late, and thank you so much, sir, once again for taking out your time. You had a busy, hectic schedule, and you had to change the schedule just to accommodate your lecture for this Noel, sir. We are so thankful for everything. Dr. Tanvi, you
Thanks
are
for the
excellent.
opportunity. I love this.
Thank you. Thank you so much for teaching, sir, all of us again. It's
Dr.
always a pleasure
Zakishan
listening to
Mittal
you.
sir also with
I
us.
am happy to see Gunjan, Tanvi, and Rohit there. Remember my last year's examination time? Hi.
So we have with us Dr. Zakishan Mittal sir also. He has also joined.
Where
Maybe
is he? He's still in the OPD?
no. So he has joined the meeting. I think we can have a remark from him as well. So if you could just unmute yourself.
Hello. हेलो।
Yes, sir, you are audible.
अच्छा, ओके। सॉरी, मैं देख रहा था तुम लोगों को। So, बहुत लंबी क्लास चल गई ये तो पूरी। डॉक्टर आशीष ने पूरा
कोई पीछे लेक्चरर नहीं था, मुझे मालूम था। बोलते
क्या
जाओ, कोई सुने कि नहीं सुने।
नहीं 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 नहीं, आपने तो यू गिव प्रैक्टिकल डेमोन्स्ट्रेशन एज वेल। लंग पे भी आपका फेवरेट आर्टिफिशियल लंग पे भी डेमोन्स्ट्रेट कर दिया।
मेरा गिरिधर का मैं मंगला का स्लाइड था, दैट्स फाइन।
So was there any और कुछ क्वेश्चन वगैरह था?
Covered almost all the part. Very, very special thank you to Ashish sir for sparing time, and Dr. Rohit, Dr. Tanvi. We have given you a very shorter duration of time to prepare everything, but I think I've done full justice to the topic. Thank you everyone for joining. Sameer sir, can we close the session?
Yeah, please. Thank you. Good night.
Thank you, sir.
Thank you very much. Bye, Jai Kishan.
Thank you, sir. So you are always ready for the ventilation workshop and ventilation teaching. So it's always a pleasure to listen you and learn from you.
एक्चुअली क्या हुआ है, रियलिटी वो है कि लॉन्ग बैक व्हेन आई वाज एट लेक्चर वाडिया, रात को वेंटिलेटर खोल के बैठते थे, बिकॉज़ दोस वर द डेज व्हेन नो वन विल कम टू रिपेयर वेंटिलेटर मिडल ऑफ द नाइट।
Right.
खैर वो बेयर वाली पूरी सीरीज वहां पड़ी थी वाडिया में, और उसको कोई देखने वाला नहीं था। तो रात को बच्चा बच्चा व्हेन आई वाज लेक्चरर देयर स्टेइंग देयर फॉर 24 आवर्स, तो रात को वेंटिलेटर बिगड़ता था तो फोन और लैंडलाइन पे फोन लगाते थे। वो फ्रैंकलिन डेविड को, जो बेयर का डीलर था, ही विल टेल मी ये करो, कोई सिस्टर बच्चे को बेक करती रहती है और आप वेंटिलेटर को रिपेयर करते हो। सो
But then only you done actual ventilation. Basic principles तो वहीं से सीखते हैं।
बस वही वहां से सीख गए और कुछ नहीं है। यू लव इट सर।
Good. Thank you, sir.
Thank you, sir. Thank you, bye. Thanks a lot.
Tanvi, it was a nice
Thank you to
presentation.
your team.
Thank you, sir.
Yep, all of them are there. Good.
Thank you, sir.
Bye-bye.
Thank you.
Bye. Good night.
Good night. Good night.
Night, everyone.
Amore, volevo sempre che